so the next neural test we're going to go through is a pro-knee bend or a femoral nerve test. So again, Glenn's going to take us through that, and we'll just kind of discuss things as we go through.
Great, so a couple of different ways of doing this that I like. First thing I'm going to do, I'm going to bring your bottom leg up. So bend that bottom leg up for me, take that in your hands for me, PJ, and pull that up. So you can either get him to pull it up as far as he can, or you can have him just extended arms, which is another standardised way. You can have 90 degrees. Again, with all these tests, however you standardise it on your first time, just reproduce it the same each time, and note it down in your notes appropriately. So the way I prefer to do it is to bring the knee flexion component on first. So I bring PJ's leg up to here, and I can plantar flex the ankle really well, and I can block him into knee flexion. So I've got him in that position. I can stabilise his hips as well. I've got a lot of support and a lot of control with the leg, the lower limb, and then I can just slowly start to bring the leg back into hip extension. So we're coming across here. We're keeping every component on at the time. I'm feeling a bit of resistance there. So I'd hold that position, and now we've already got PJ to flex his head forwards. That's your standardised start position. If you extend your neck back for me, does that change it? Because obviously this is a massive stretch for rec fem and the hip flexors here as well. A lot of people are tight in those areas, so this is how you differentiate that out. Now in practice, what I've found, especially older clients, don't always feel very comfortable when you're forcing their knee into full flexion, and they might have a bit of OA in the knee, might be a difficult position for them. So I used to struggle around trying to bring it into this position, but now I haven't got the same amount of support, I haven't got the same amount of control. So I switch over, so I bring that foot onto this hip now, and then I can block in there. Now the negative part of this is that you lose your plantar flexion on your ankle, but you're still sensitising it in the head, so it might just change the range that you will see with the test. And then you'll get your standardised position, so maybe it'd be 90 degrees so you can reproduce it, and then from here you'd keep that angle on as you come back, and you can see with PJ I'm getting a little bit further, feeling a little bit of resistance there, and then we'd sensitise that in the same way.
The head, so again you're just asking for symptom reproduction, how it changes. If he's moving the head and it's changing those symptoms, then it's suggesting more neural, because you're not actually changing any of the myofascial stretch that you're getting through the lower limb, but you're changing the nervous system as a whole. So I think that's the important thing. If you were getting no change with the head, then it's more likely to just be a stretching myofascial or muscular stretch through there. Rather than if you get a change with the head, then it's suggesting maybe more of a neural component.
Exactly.
So I really like that one. I think it's a really good one to do. You can add in little different things with the hip as well. So you could take it into a little bit more AD duction, more AB duction, depending on as you get better with the test and you practice, then you can just modify it slightly to see how those things affect that.
You can bring in a bit of abduction, a bit of internal rotation if you're thinking about obturator nerve, for example. If you've got pain down the inside of the thigh and you're trying to differentiate between adductor pain or neurogenic pain, and you'd use the head as the sensitizer there. We show that in a different position, which we're going to go through as well. And I think it's good to practice these as well, because this position is a fantastic position for treatments. So I do lots of METs, that kind of stuff in this position, lots of passive stretching of hip flexors, all that kind of thing. So getting a good handhold and handling skill in this test sets you up for some really nice treatments as well.
So like your neural gliders as well, you could do in this position as a treatment if you thought someone had some neurological sensitivity, and having that good handhold and that really strong base means that you're going to feel much more comfortable, easier for you as well, and you're going to protect your own back, and then you get a really good position for the patient and standardised position for the patient as going forwards with that as well. So I think that's awesome.
Yeah.
Great.